Healthcare Ethics and Global Health Ethics at Western University in London, Ontario. And it's my pleasure to be your host today as one of the co-organizers with Jude Sinha at Ottawa U and colleagues from the University of Hong Kong and York University for the webinar series, Infectious Disease Outbreaks, Social Sciences at the Heart of Surveillance, Prevention and Intervention Strategies. So the goal of this webinar series, for those of you who are joining us for the first time today, is to reflect and provoke discussion on lessons learned from Ebola that can inform current strategies and future strategies to address both COVID-19 and future pandemics or outbreaks, mitigating not only the health and health system casualties of this pandemic, but also, sadly, the proven and potential inequalities that can be exacerbated at local and global levels in any public health emergency. The series launched in November with a first webinar on COVID-19 in low and middle income countries. And in December, this was followed by a webinar on the impact of outbreaks on health services utilization. At the end of today's session, which is being live streamed and archived, we will give you details on how you can access the past webinars as well as this one. And as the title of the series does indicate, we're foregrounding social science research. It's also foregrounding several projects funded by the International Development Research Centres of Canada and CIHR that bring into focus specific and particularly challenging infectious disease outbreak settings. And ultimately, in focus is the question of why and how international organizations, national governments, and local populations have responded in the way they have to infectious disease outbreaks and with what impacts. So our focus today, as you know, is trust and community engagement. We have 3 speakers. I'm going to introduce each of them now, and then we'll launch into things. So we have Professor, I'm just gonna, it's fine. Okay, we have Professor Mandi Kader, who is the chair of the Foundation on Health and Sustainable Development at FOSAD and executive director of the Center of Research on Priority Diseases in Guinea-Conakry. He has over 40 years of experience cutting across academia, clinical trials, public health management, and epidemic preparedness and response around the world. He played a crucial role in the 2014 to 2016 Ebola outbreak, chairing the Ghanaian Ebola Research Commission. He served as co-principal investigator for several clinical trials, including the Guinea RVSV Ebola vaccine phase 3 trial, and is well known across the region for his role in epidemic preparedness and responses. He also is very well respected amongst Ebola survivors in Guinea for his skills at engaging diverse patient and research participant populations. Professor Kader Kandé is currently member of the COVID-19 Guinea Scientific Council, and he is the Africa lead for the IDRC project Strengthening Ebola Research Ethics, on which I'm a co-PI. His talk will focus on operational and social challenges related to control of Ebola and now COVID-19 in Guinea, as well as a unique toolbox developed to support research amongst limited literacy adults in West Africa. We also have Harris Ali, a sociologist at York University who studies the social, political, and environmental dimensions of disease outbreaks and disasters. Harris Ali has conducted various studies on different types of infectious disease outbreaks in various parts of the world, including E. coli in Walkerton, Ontario, tuberculosis amongst the homeless in Toronto, community-based responses to Ebola in Sierra Leone, Liberia, and the DRC. And with his longtime research colleague, Roger Keel, he also conducted a really relevant to the current pandemic comprehensive study of the 2003 outbreak of SARS in global cities, which culminated in an edited volume on SARS called Networked Disease, Emerging Infections in the Global City, that has recently been recognized by the Globe and Mail newspaper as one of the top 10 books that offer lessons from past pandemics. So congratulations, Harris. He is currently a co-principal investigator with Fuyuki Kurosawa on a CIHR grant that involves big data analyses to understand the role of social media in countering anti-Asian racism during the present COVID-19 response. And Professor Ali's presentation will focus on the relationship between risk perception, trust, and place and how this relationship influenced the unfolding of the community-based response to Ebola in West Africa with implications for COVID. Finally, we have with us today Professor Shelly Lees, a medical anthropologist with 25 years experience in research on public health issues, including on HIV, STIs, gender-based violence, cancer, and maternal health. She has over 15 years experience based in East Africa, and her global health research has expanded recently so that she is managing social science projects in Sierra Leone, Uganda, Brazil, and DRC. Thank you so much for joining us today. Her current focus on anthropological perspectives of epidemic response is focused on Ebola vaccine clinical trials and medical humanitarian response. She's investigating the social and political context and consequences of biomedical approaches to public health emergencies. She's also involved in the Alert Consortium, where she conducts research on community engagement for biomedical research for epidemics across sub-Saharan Africa. Her presentation will provide anthropological insights on community engagement for emerging epidemic vaccine development and deployment based on research she conducted in Sierra Leone, DRC, and the UK. So each of our presenters will speak for 15 to 20 minutes. We won't be taking questions right after the presenters individually, but at the end in a Q&A. And I will ask that you put questions up in the chat as these emerge for you so that we can revisit them after. We'll take note of these, and after the three presentations, we can get into the Q&A. And before handing the floor over to our first speaker, who will be Harris Ali, I would like to start off with an acknowledgement of the land from which I'm hosting the webinar today. So for those of you less familiar with recent Canadian history, in 2015, the Truth and Reconciliation Commission outlined 94 calls for action regarding reconciliation between Canadians and Indigenous peoples. So acknowledging where the university resides and where I reside is part of upholding TRC recommendations and paying respect to the original peoples on the territory from which we are speaking. It's also a means of expressing and normalizing commitments to building relationships with and responsibilities towards Indigenous communities. So I myself am born on Algonquin territory in Ottawa, and I speak to you today from the city of Hamilton, traditional Anishinaabe, Mississauga, Haudenosaunee Neutral, and Huron-Wendat territory. And on behalf of the Western University community to whom I belong, I would like to acknowledge the presence of the university and the city of London, Ontario, on the ancestral lands of the Anishinaabe, Haudenosaunee, the Lenapanawek, and the Adirondack peoples, as determined by the Dish with One Spoon Treaty. The land continues to be the home to traditional Indigenous peoples who are contemporary stewards of the land and critical contributors to society more generally. And with that, I will hand things over to Harris Ali.
Okay, let's see. And yes, can everyone hear and see me okay?
Yes.
Yes, okay, great. Thank you, Elsie and Jude and Sabah for organizing this panel session. And today what I'll be talking about is the role of trust, risk, and community-based initiatives during the Ebola pandemic. And towards the end, we'll look at some of the implications of that research about trust and risk for the present COVID-19 response. This is part of a larger research project that was looking at community-based initiatives in Sierra Leone and Liberia to see how the lessons learned from West Africa could be applied to the DRC. That was the hope. And we had a series of workshops in the DRC to teach about the community-based response. But as I said, today we're going to talk about trust and risk. And trust in particular has been sort of identified as one of the key factors that has characterized the response, or rather distrust. And so that's what I want to begin with. During the early initial response to Ebola, many had become deeply suspicious about public health interventions such as forced quarantines, prohibition of cultural barrier rights, consumption of bushmeat, and even medical care. And it's been noted, Eugene Richardson, for example, a medical anthropologist, has observed that this type of local distrust and non-compliance with Ebola responders is commonly criticized as being an irrational response, of uneducated populations who need to be convinced of the veracity of the Western scientific approach and to reject their false cultural practices and beliefs, like funeral rites and things like that. But the point is, Richardson notes that this perspective is not only inaccurate, but reinforces sort of Orientalist biases. It reinforces a particular colonialist paradigm of causality that obscures the role that the determinants of health and the political and social context play in creating distrust. And I think this is the key point for the presentation today. It's about how the context, social, political, economics, has influenced how the community outbreak has unfolded. Okay. So, let me go up. So the key questions that we'll look at, for some reason I can't see my top screen because I have these icons with the sharing stuff on that. I don't know how to get rid of that. Okay, so basically we're looking at how trust and risk have changed over the course of the unfolding of the Ebola outbreak, okay, and how we can account for those changes. Okay, so to begin with, we can start by saying, okay, what is risk and what is trust? And there's been certain Western theorists who have dealt with risk and trust in detail, well-known social theorists like Ulrich Beck and Anthony Giddens. But as we'll see, that they use a sort of Western conceptualization of risk and trust, one based on a certain assumption about rationality, Western assumption about rationality and rational choice. And it's devoid of the context. So here we want to bring in the context back in. So risk is simply about dealing with conditions of uncertainty. And when you have conditions of uncertainty, you have gaps, and therefore this requires a sort of jump in faith, a leap in faith to deal with this problem of not knowing everything. So risk and trust are very intimately related, and this we use as an entry point to the analysis. Okay. Move this here. Okay. Now, one of the most sort of well-known, sort of well-publicized aspects of the Ebola response was this idea of resistance, because this is very dramatic and it catches the newspaper's eyes, and it's about confrontation and conflict. And I'm sure you've heard about this and have read about this. And in the top is the situation in West Point, which is an informal settlement in Monrovia, where a lockdown provoked a certain response. And then, of course, in the case of the DRC, there's these images spread around the world about the burning down of Ebola treatment centers and such, very dramatic and vivid examples. Okay, and as we'll see, a lot of this resistance has to deal with the issues of risk and trust. And we'll see that one of the ways to sort of combat issues of distrust and exaggerated risk perceptions to a certain extent is through the community-based initiatives. And the community-based initiatives involve the direct involvement of the people so that they're trained in specific ways on quite technical exercises in some case. So they're trained in response training, including case identification and contact tracing, raising community awareness and education, implementing hygiene measures, community surveillance of disease incidence and spread, implementing isolation, quarantine, and triage measures, provision of food and water, okay? And these community-based interventions play a key role in changing people's risk perceptions and raising their levels of trust, or at least addressing the mistrust issue, okay? And as you know, many of you know, the initial response to EVD, to Ebola, was not very effective, but later on it did become more effective. And we'll argue that one of the reasons it became more effective was because of the introduction of community-based initiatives. And at least in Liberia and Monrovia in particular, community-based initiatives were, developed and implemented by my research partner here, who is recognized for his work as a Time Magazine Person of the Year. This is Dr. Masoka Fala, who's on the right. But he had a whole team of young people and certain older individuals in Monrovia from the community that were involved in implementing the community-based initiative there. So I'm largely drawing on his experience. And we did focus groups and key interview informants in 3 counties in Liberia, including Lofa County, which in the town of Foya, which is close to where the initial outbreak started from. Some people say from Guinea. Okay. So these are the details of the methodology, which I don't want to get into too much, but this is a retrospective study. So the interviews were done about 3 years after the EBD outbreaks in Liberia. Risk perception, we define simply as the level of conceived threat people associate with EBD, and trust refers to the level of faith people invest in others or institutions with respect to the truthfulness and reliability of the claims that are made. Okay, so risk and trust have to be embedded in sort of the local context in which they play out. Okay, and when you look at the local context, you cannot avoid considering things such as the corruption of foreign and local political elites, especially government investment and interest and how they supported private interests, mining, forestry, rubber, iron. You see this all the time in many examples. For example, many of the roadways in parts of Africa are there to service the mining, forestry, rubber, iron companies instead of servicing the people. So there's a neglect of the people, neglect of the public good. There's no investment in what protects the social welfare, the collective good. And so this is the context that we're dealing with, right? And of course, there's the decimation of the public health system in West Africa and Liberia. You can see that the figures that there's only 10,052 healthcare workers, most of them in Monrovia. Many well-educated, trained health professionals had to flee for reasons of safety during the civil wars, both in Sierra Leone and Liberia. So a completely decimated healthcare system, which of course made it difficult to mount an effective response. Okay, but they still did, as we'll see later on. Okay, now one of the things that comes up often is about this reluctance to visit Ebola treatment centers, and often this is seen as a sort of irrational response. But even if you look at this image given here, you can see that this is a very uninviting and inhospitable place, this Ebola treatment center, with all the barbed wire and solid walls, and people were not able to visit their loved one. And this is an alien way of doing healthcare, of the family not being involved to take care of loved ones who are ill. This is a nonsensical sort of perspective. So this is actually a rational response. Like, there is something suspicious about the Ebola treatment centers. It's actually very rational if you consider the logic of the people. Okay, so that's something that the response needs to be taken into consideration. Okay, because I'm limited in time, I don't want to get into too much about the colonial history of Liberia and Sierra Leone, but that is what sets the backdrop to the distrust that we'll be talking about today. Okay. So certain other things that came up, though, that I want to mention here are things like rumors that began to circulate that foreigners at the health centers were stealing body parts, that they were sorcerers, that they spread illness through magical means, that the foreigners were involved in a plot to depopulate the people by actually infecting them with the Ebola and things like this, right? This is part of the whole context of suspicion and distrust. Okay, and again, it's about the local rationality. This isn't as irrational as one would first think, right? And this is why we can say what's rational to one person may not be rational to another in another context. Okay, so to the Western mind, the reactions of Liberians were irrational. but to many Liberians, the reactions were perfectly rational. And it's not just an issue about culture, but about the political economic as well. This is why I went into the whole colonial history sort of background and mentioned that. Okay, and there's a nice article by Wilkinson and Fairhead that's given here that deals with the political economic, and it's influenced my thinking a lot. But as a sociologist, I know that there's a sort of subjective aspect to risk. And that comes in when you talk about the personalization of risks. Oftentimes, because I teach environmental sociology, one of the questions that arises is, why are people not so concerned about climate change? It's going to be a catastrophic risk, end of the world, so on and so forth. Why are people not acting urgently? And one of the answers is because climate change is for many still a distant, abstract risk. It's not personalized. It doesn't impact on them directly in their personal lives, right? So this is true with many risks, including Ebola. It wasn't until people saw firsthand their loved ones succumbing to the disease that the risk was perceived as real, okay? And then people were more willing to change their behaviors, okay? And so we can look at the sort of the earlier phases of the ineffective response to later phases when the response was more effective. And these are sort of quotes from the earlier response in terms of changes in trust to the response team. One person notes that when the response team came, they would dress like beggars. They would not talk to you nicely. They will talk to you harshly. They came, sprayed the whole place with chlorine and went away. They will not talk to you politely. They were not giving us encouragement. The only thing they wanted us to come and carry the person away so they can get their money, okay? So one consequence of this distrust in the official responders during the initial response was that some went to seek help and services of the traditional healers, okay? Now this, of course, is common practice, that you would first see the trusted people, and then if they don't work, if the traditional healers don't work, then as a second resort, then you go to the Western medical people. So this was a continuing practice that was happening, okay? And there were various quotes to support that idea. Now, in the Muslim community of Banjul Red Hill, one response recalls a transition that happened later on during the response after the community-based initiative was implemented. Before, the response team made us feel bad, but later they were trained to the extent that they could actually inform us properly. I think they were slow because they lacked the proper health worker training, but after being trained through the community-based initiative, then they came to the community and responded to our questions. So there's a greater level of responsiveness, which enhanced the trust after the community-based initiative was implemented. Okay. Same respondent further outlines the shift in risk perception and trust that encouraged communities to follow the prescribed public health outlines. To eradicate Ebola, we realized we had to stick to the rule. We're willing to learn. There were those who didn't believe that. They said Ebola was a money-making thing, but eventually they let that belief go. People were willing to stick to the rule, right? So this idea of sticking to the rules is an important one, and it comes with the building of trust. And you still see this thing happening with the COVID response in North America, that you have QAnon, conspiracy theories, all these people promoted by Trump, all this idea of not following the rules, right? Because of suspicion. So this is a kind of universal thing that goes from culture to culture, okay? Changes in risk perception, you can also see between the early stages and the late stages. In the early stages, people refused to go to the Ebola treatment unit. One person says, look, if I became sick, I wouldn't have reported myself to the Ebola treatment unit, because if you listen to the radio, there was no word of encouragement, nothing that said that if you go to the ETU, you'll come back alive. For me, if I became sick, I was going to separate myself from my children and be alone. So they would do that alone by themselves. They would not go to the Ebola treatment unit, right? But later on, there was a change in attitudes, and people said, well, if I did get sick, I would go to the Ebola treatment unit. So the community-based initiative did something to change people's perception and to consolidate trusting relationships. Okay. So some developments that the community-based initiatives to disease response will have to consider in the future, because it seems on one extent that it was very successful, the community-based response, and it was, but it did have certain problems associated with it. And this needs a bit of greater attention. Community-based initiatives were not a panacea. One of the things that did happen with the community-based initiative was that distrust arose from within the community itself, okay? Because basically people were saying, oh, someone's squealing on me, that, they're saying I have someone sick in my household, and they shouldn't be telling the authorities about me. And there are other sort of situations of tension, for example, when people were accused of being employed by the community-based response because of favoritism or nepotism, because those kinds of jobs in the community-based response were given a little bit more money or an opportunity to make money, and some felt that this was given to certain people and not others, and this was a bias. So this led to community fragmentation and distrust within the community itself. So these sorts of distrust, suspicion within the community, as opposed to against foreign workers, this has to be addressed as well, okay, as research proceeds. Okay, and so these are quotes. Yeah, with Ebola coming into the community, it brought division within communities, family, and let's say neighbors. Because, for instance, if you saw your neighbor sick, the rule said we had to report that, and then the response team would come and care for that person. The rest of the family of that person would become angry with you. People were no longer really free with one another, and this scattered them because some people will not interact with each other and avoid each other. Right. And you even see this in the present COVID response in North America. This is all this discussion about online shaming and reporting people and this sort of thing. It's a similar thing. So to conclude then, how did the Ebola response sort of influence the present COVID response? And, to address this question, we looked at the sort of network social infrastructure that was established with the Ebola response, okay, and how it was mobilized during the COVID response. So in Monrovia, the key leaders in the community-based COVID response were the very same leaders from the Ebola response, and they based their strategies on their previous Ebola experience. And because of this experience, they're able to quickly mobilize community volunteer groups to go around and educate people about COVID, form well-organized teams to keep track of the residential household compositions of all homes in the community block, establish hand washing stations manned by youths at the entrance to informal settlements. And this is another thing about enforcing quarantine. You see in other cities in the global south that sometimes quarantine was enforced by, the drug dealers and people like this. Right, it's an interesting phenomena that developed. Anyways, reconvene the teams that tracked the bodies of the deceased during the Ebola outbreak, so that by April they already had compiled detailed reports regarding COVID. Ensure that all community members involved in the response were masked and were masking. Arrangements to work with local tailors to produce masks for those who could not afford them. Launching a program to make it compulsory to wear masks and so on. So all this ability to organize was based on the previous experience with Ebola. And so the COVID response benefited from that for sure. Okay. So just as the concluding remarks, the Ebola virus outbreak in Liberia was challenging because of initial resistance of communities to adopt safety and prevention measures outlined by officials. The resistance was grounded in a history of mistrust of government, private extraction industries, and NGOs that were corrupt, exploitive, and mistreated locals. The findings highlight the importance of public health experts and outbreak responders to gain an understanding of the power dynamics within the specific social and historical context in which the outbreak unfolds. Again, this is important. Another example that comes to me is one of the people that I interviewed said, Ebola, why did it come all of a sudden? And why are people telling us not to eat bushmeat? Because we've been eating bushmeats for hundreds of years. We didn't get Ebola then. Why do we have Ebola now? So this led to a certain suspicion because it doesn't take into account social and historical context. And by the way, that's a valid question. Why did Ebola always come now from the bushmeat if people were eating it for several hundred years? right? I mean, I posit that one of the differences is the environmental changes that we're seeing at an intensified level today as compared to the past, but this is another discussion. But the person has raised a rational question. Anyways, in this light, when examining infectious disease response, local context alongside necessary medical interventions should be considered. Community-based initiatives offer a more integrated epidemiological response for better community health outcomes by offering the potential to incorporate the local context into their response. So acknowledgements, this presentation is based on a paper that I've developed with Jared Rose and Catherine Wells. Jared is a PhD student and Catherine is an MA in disaster sociology who finished that a couple of years ago with me. And as I said, Dr. Masoka Fala and Dr. Laura Scrip and members of the CBI were responsible for the data collection. These are the members of the CBI community-based initiative in Monrovia, and it's funding support I gratefully acknowledge. And if you want more information about our particular project, this is the research website, ebolaproject.info.yorku.ca. Okay, thank you very much.
Thank you very much, Dr. Ali, for that presentation, which also is a great entry point for thinking about all the social historical layers that can complicate and create resistance and health seeking that is not in line with the rules, as you put it. So really looking forward to some of the questions that are coming up in the chat. We're going to continue here with a presentation by Shelly Lees next. Shelly, I'll hand things over to you. J'aimerais juste souligner que si vous êtes francophone, bienvenue, et vous pouvez mettre vos questions dans le chat en français ou les poser en français à la fin. Puis on va être capable de les traduire, il n'y a pas de problème, et on apprécie beaucoup votre participation aujourd'hui. Merci. Okay, Shelly, over to you.
Thank you very much. I hope that I've got the technology and I'm sharing. There's a bit of a delay here. Can you see?
We can, you just need to put it in presentation mode. Looks great.
Okay, I have got it in presentation mode.
Yeah, that does happen to me sometimes. You might want to just unshare and reshare.
Yeah, should I maybe, okay, sorry about this. There's always something, isn't it?
Yes.
Okay, so share there.
So
apologies about this.
Yeah, no problem. So a couple of the questions coming up in the chat, just for your note, Dr. Ali, while we get ready, you can be thinking about Ernest from RDC points out that utilization of the police and the army in the Democratic Republic of Congo in response to hostilities and challenges of getting teams into areas for infection control during the Ebola epidemic has been quite controversial. So one of the questions that will be great to discuss is, if, as Ernest says from RDC, negotiations are ideal, but what do you do in these extreme circumstances where response teams are having trouble and are being threatened in hostile communities? So that's one of the questions from Ernest. And then from Z Lung from IDRC, IZ. What are some ways to apply these lessons to national or regional scales? How can this be applied to sites and communities which may not have experienced outbreaks before and therefore don't have resources, outbreak responders, local organizations who have the knowledge and capacity for applying community-based approaches when an outbreak does occur? And I definitely, I think that will be a great question as well for everybody on the panel, and no doubt. Shelly.
Yes. Okay, I've got it in. I'm trying again.
Yes.
Can you see that now?
Beautiful.
Oh, wonderful. Okay. Okay. Okay, thank you very much for this. Well, good morning, good afternoon and evening, wherever you are. Many thanks to the organisers for this really pertinent webinar. I mean, it really does relate to many conversations that we're having in the UK. around public health response to COVID-19 and the role of social scientists. For the past 15 years or so, I've been conducting anthropological research on emergent diseases. I mean, initially on HIV, and then Ebola, and now COVID-19. And my research has very much focused on local perspectives on epidemics, as well as critical reflections on epidemic response, including clinical trials. I think, as with others over this time, I've encountered many challenges when arguing for the importance of social science perspectives. I think whilst there has been a recognition of the importance of social science perspectives of the HIV pandemic, the 2014-16 West African Ebola epidemic really revealed, I think, to the international public health community, the importance of addressing social science perspectives on epidemics. And I think, you know, we still have a long way to go, but here I want to present some of the perspectives that we hope from Ebola that can be taken up for future epidemics. Now I can't press the next. I lost you, sorry. Okay, have I gone to the next slide?
Yep.
Great, okay. I think really for this slide, I won't spend very much time, because I think Professor Ali has really described in detail what we've learned from social science perspectives on epidemics. And I think particularly shown understandings of local and global political economies, historical legacies, especially of inequality, marginalization and mistrust, particularly in service providers and public health responders, and how these do inform acceptance of public health interventions. I'm moving between. Pause.
And Shelly, the slide is just.
Yeah, okay. I'm moving between. I really apologize to us. So I think Professor Ali has provided in detail some of the very clear issues that arose during the West African Ebola epidemic, and how social science has really given much clearer insights into these issues. And I think, sorry, I'm moving between the two. I think it's really important, really, in summary, to say what we've learned from the previous epidemic, particularly Ebola, is that anthropologists can describe factors that facilitate the movement of pathogens through understanding social networks, patterns of gender, age, and kinship, and situating these within social, economic, political, and cultural systems. And also, and I think this wonderful paper by Hannah Brown and Anne Kelly really looks at the issue around One Health, and how human engagement in the material world and institutions and animals facilitate the movement of pathogens. Central to the response for the Ebola epidemics was the rapid development of vaccines through clinical trials. Ebola vaccine trials were set up really very early in the epidemic. The first vaccine to finish a clinical trial and to be rolled out during the epidemic was what's now known as the Everbo vaccine, which was granted approval for emergency use and used for ring vaccination at the tail end of the epidemic in Guinea and Sierra Leone. Since then, it's been used for ring vaccination, 3 Ebola outbreaks in DRC. The Ebovax alone trial, which is testing the Janssen Prime Boost vaccine, was set up in Sierra Leone in 2005. And Louisa Enria and I have been conducting anthropological research about participant and community experiences since then. In 2019, a further Janssen vaccine trial was set up in North Kivu to test the same prime boost vaccine. And my colleague, Mifanoui James, and I have continued to conduct anthropological research on participant and community experiences of this trial. And I think what's been particularly interesting is that the social science research has been conducted during the COVID-19 pandemic. And therefore, ideas around epidemics, vaccines have intersected for the participants and the community in Goma, where the Ebola vaccine trial is being conducted. I want to just describe a couple of studies that that I'm leading on, working with some amazing colleagues to describe what we're learning about the deployment of vaccines. The Avid Study, which is an anthropological exploration of facilitation barriers to vaccine deployment and administration during disease outbreaks, was actually set up in 2018. And here we've taken a case study approach across DRC, Sierra Leone, Brazil, India, and Uganda to explore a range of vaccines for emergent infection. This project takes a critical anthropological approach to exploring what actions can be taken to optimize vaccine acceptance during a disease outbreak. We're exploring logistical challenges to vaccine deployment and administration, including system weaknesses exacerbated during times of disease outbreaks. And we're also exploring distrust in national and international bodies that provide vaccines, which are also amplified in times of emergency. And finally, we're exploring rumors and misinformation, which are commonly spread during times of outbreaks, especially when the diseases are new, unfamiliar, or there's an absence of information available. And alongside the Ebovax alone trial in Sierra Leone, we're conducting studies to look at expectations, hesitation, and acceptance of Ebola vaccine and vaccination strategies. And here we want to understand the acceptance of different strategies and prioritizations for different groups in Sierra Leone. And I think this is really highly pertinent to COVID-19 vaccine rollout. So here I want to give you just some sort of high-level insights from our research, which I think very much overlap with the work of many of our colleagues elsewhere, and probably many of our colleagues on the call. Our research has reinforced long-standing work in medical anthropology that's highlighted hesitancy, concerns, and resistance to interventions such as vaccines as tensions between biomedical and local knowledge. We have learned that in order to understand local power dynamics in the delivery of vaccine trials and participation in trials, ideas of fairness and the nature of trust have been important for the recruitment of participants. And alongside this, ideas of justice. Setting up clinical trials in an epidemic where people are understandably fearful also requires an appreciation of what motivates people to take part in trials. The Ebola vaccine trials where we're conducting research has taught us the importance of ideas such as altruism, sacrifice, curiosity, and hope in participants' decision making, even or despite their fear. Our research on vaccine deployment has found that vaccine perceptions are complex and multifaceted with historical, cultural, and political influences. Our research has identified issues of trust and legitimacy in how acceptance of vaccination reflects social relationships, culture, and values. We suggest a more nuanced understanding, though, of acceptability of vaccines as either confidence or hesitance. And as with others, we've also explored community and knowledge of vaccines at interface between animal and human health from the perspective of trust and social relationship. However, and I think we're seeing this on a global level, there remains gaps in the evidence for the potential issues for vaccine development and deployment for COVID-19. COVID-19 vaccines have been framed as a solution to end the pandemic. A number of vaccine candidates are in development, and according to WHO at the moment, 15 are currently undergoing clinical trials with highly promising results recently published. There are currently global efforts to roll out these vaccines. However, a number of ethical and scientific concerns are emerging. Such questions are circulating in the public and raise concerns about public trust in vaccines. For example, the global effort of the pandemic is a major driver to the speed of vaccine development. And this may raise concerns about sufficient testing for effectiveness and safety amongst communities. Limited long-term data on safety for approved vaccine and the use of novel platforms may also invoke anxiety. Alongside these anxieties are questions about the duration of immunity and whether these vaccines will prevent transmission. Furthermore, as we're seeing in the UK, government policies on timing between doses and mixing vaccines outside of clinical trials are eliciting anxieties. And finally, ethical questions are circulating about who is prioritized for vaccination and fair global distribution. This is especially important to address inequalities, both nationally and global. Thus, we continue to call for social science inquiry into vaccine science and deployment. As I've stated above, our social science research has demonstrated that social inquiry is essential to the success of vaccine trials and the deployment of vaccines. Thus, I argue that it's important to integrate social science research in future COVID-19 trials and deployment to understand individual community concerns and expectations. It is especially important to understand trust in vaccines as political, social, and economic and historical. This will help us to understand potential facilitators and barriers to uptake beyond issues of vaccine hesitancy. It is especially important to understand how political and social structures, social justice relate to COVID-19 vaccine. This requires a political economy perspective at local and global levels. Such a perspective, for example, could reveal how governments and COVID-19 country coordinating bodies can improve public trust, acceptability, effectiveness, and uptake of COVID-19 vaccines. It is important to identify community dynamics and patterns of trust. This means understanding contextual determinants of misinformation and disinformation, and identifying both formal and informal authority structures and informal sources of information influence to be able to ensure that different kinds of actors and groups are involved in discussions. Finally, social science inquiry can aid with the exploration of social justice and the access to COVID-19 vaccines, particularly in resource-poor contexts. I'll put these all out. So in conclusion, the role of social science to support community engagement is increasingly recognised. Social scientists can provide recommendations for community engagement in the clinical, for clinical and deployment teams to be able to tailor their operations in locally relevant ways. And thus I call for the, apologies. The integration of community, as a call for further social science research to inform ways to integrate participant and community perspectives in deliberations about aspects of trial design and procedures to ensure that these take into account specific benefits, concerns, and social cultural contexts. Social science can also create, inform ways to create an open and two-way dialogue with participants and relevant communities. And finally, ensure that engagement does not focus simply on misinformation or the need for more information, but also identifies sources of mistrust and potentials for community dialogue and response to them in dynamic ways. And just to finish, there are a couple of briefs that the Social Science and Humanitarian Action Platform have produced that pretty much summarize these key issues. And finally, I'd like to acknowledge the social science colleagues that I work closely with. Thank you.
Thank you very much, Shelly. And I'm sure I can see that there are a lot of questions coming up in terms of the relevance to Canadian, UK context, as well as more questions about religious and social factors. We're going to move along to Mandy Kader's presentation. Mandy, est-ce que vous êtes là?
Oui, je suis là.
Est-ce que vous voulez que moi je fasse l'écran ou que vous le fassiez vous-même?
Oui, je peux partager l'écran parce que je vais mettre quelques photos.
Parfait, parfait. OK, alors c'est à vous. Go ahead, Mandy Kader. Lovely to have you. I introduced you at the beginning just when you were connecting. So everybody has heard your bio and you can jump right in. Thank you.
Hello, everybody. I'm Mandy Kader Konde from Guinea Conakry. I'm wondering if you see my presentation on the screen.
Yes, we do, but it's not the full screen and it's not the first slide.
Okay, let me start with this technology.
Oui, on est sur la diapo 12 là, je pense.
Ouais. Is it correct now?
It's good, but not full screen yet. Go écran, mode présentation là. Il faut appuyer. Ah, c'est parfait. Parfait.
Okay, sorry, my English is very bad, but I will try to do my best. And second, I'm not a sociologist, but I learned working with socio-anthropology during Ebola outbreak here in Guinea. I hope I'm trying to move to the second slide.
La petite flèche en bas à gauche.
Okay. The background, Guinea used to face a lot of public health emergency like measles, cholera, yellow fever, until now, meningitis. But during the unprecedented Ebola outbreak in Guinea, I found that was a very challenging situation with the impact on social, economic drama for the country, but it was also an opportunity for the health research and development. What should Guinea have learned from the Ebola outbreak to the response to COVID? As you can see here in this slide, Ebola outbreak, the epicenter was in Guinea, and the pattern was from rural area to urban area. The most deadly AVD with 28,000 cases and 11,000 deaths with case fatality rate 39% widely. that epidemic spread to 9 countries and 3 continents, and that the reason WHO consider that epidemic like the public health emergency as an international concern. But we can say also it's the most duration with 3 years from 2004 and 2006. And, that was a very, very long epidemic response, more than DR Congo. These slides to show you the epidemic curve, and you can see Guinea had more than 3,000 cases with more than 2,000 deaths, a case fatality rates of 67. 1,270 survivors, and the healthcare also worker pay a tribute for this epidemic. As I said, that was a challenging situation, and we conduct a lot of main clinical trials with favipiravir, interferon, ZIMAP, vaccine trial, convalescent plasma. And also we were facing with survival and viral persistence. What we can say that socio-anthropological study help a lot on the response side for this huge epidemic. Now, you can see related to COVID-19, the epidemic was not high like the one with Ebola outbreak, I can say fortnightly. And you can say until now, the first cases was occur in March 12 in 2020 with only 81 deaths, and active case is now around 733 cases. The magnitude is not high than the first one, but people were saying, is that going to be the same picture or the same figure? But we saw in some neighboring countries like Senegal and other countries that a second wave is coming. That means we need to be patient and to be to pay attention for these epidemics. The major strategy we conduct to control public health emergency, in particular for Ebola, was a lab confirmation with rapid test PCR and the RT-PCR, and the case management and the dignified and secure dignified burial, infection control, prevention, sanitation, communication, and community engagement. That was a very, very challenging point and strategy, as you can see further on. The logistic and security, coordination, vaccination, as well as research component. You can see here the facility lab. We were facing with gene expert to have a rapid test compared to 1995 when I was in Kikwit for Ebola outbreak. That took 1 week to confirm cases, and now people was complaining that it's taking 2 or 3 days during this Ebola outbreak in Guinea in 2014. But with a new machine, we can be able to run and to give the lab result, confirm lab result within 4 hours, because that was a big issue when people, we couldn't your body before having the test, and that was a very challenging situation during Ebola outbreak also. After lab confirmation, I'm trying to move to the next screen. We had also case management. The case management was very, very challenging also because people were saying now they don't know exactly what's happening in the Ebola treatment center, and a lot of people dying, and they say, why I'm going to die in that center? It's better for me to stay and not to go there, and that was a very important thing. And the social anthropological support a lot the response and surveillance team in order to move to get the good response on that. As you can see, that is the facility where people was hospitalized. And here was the sanitation, because also sanitation was a very big issue. Even if people come with a pump for sanitation and the environment and the houses, and people was complaining and saying, there is a lot of drug to kill people. And that was a very also a lot of rumors coming. And here you can see also infection control and prevention. And we are happy that our colleague from Toronto University came with MSF and to support in particular my NGO to run an phase 2 study with Ebola outbreak with interferon. I've again some trouble with my old machine. Okay, one of the main study during Ebola outbreak in Guinea, and Guinea was the first country to conduct a phase 3 clinical trial. But for the story, when the Ebola outbreak started and WHO called a meeting in Geneva, and everybody, like the three most affected countries, Sierra Leone and Liberia, was planned to conduct clinical trial. CDC was and London School was involved in Sierra Leone, and CDC in and NIH in Liberia, but nothing was planned in Guinea. We were able to push a little bit and to get that trial, but it was very successful. Even if Guinea was the epicenter, but we had opportunity to conduct that first phase 3 clinical trial, and that was very critical for the for the MERS vaccine. And we plan also to have a frontline care vaccination. That is roughly the ring vaccination with index cases, lab confirmation. We vaccinate the contact and the contact of contact around a ring, and that was very successful. And during this vaccination, it was also very challenging because in the ring vaccination, team go to the community with a recent confirmed Ebola cases. You never know who was who during that vaccination. And we were very afraid. This is our team on the field when we are there, and we make a lot of focus and to be careful and to take care of all these situations. But again, socio-anthropological people help to convince population and to let them engage and to participate in these also vaccination. What we learn also, they suggest us not all the four-wheel drive white one coming and maybe from time to time is more than 5 vehicles in a small village. They say, no, let's put all these vehicles outside of the village. And that was very useful also for the vaccination. Now, the main challenge during this public health emergency and the population concern was the perception related to the new disease with low literacy, in particular people with low literacy, with social cultural impact. What we saw, there is a lot of in West Africa compared to DR Congo, there was an intense movement and migration of the population. And the community knowledge, trust, and lack of community engagement with negative impact also. We had a lot of deficit of communication, a lot of rumor, in particular at the beginning of the outbreak in Guinea, the denial of the disease and resistance, violence, and murder. We were not lucky in some area, they kill people. You can imagine people coming to support you, to run, to take care of you. And because the people in the capital saying to their family in the village, saying, oh, these people is coming to kill you. And that people was waiting and ready to riposte, and they kill some people and health worker, frontline and worker, as well as some administrative people. The third one was behavior and politician intervention. During Ebola outbreak, as well as COVID outbreak, there was a lot of challenging the political interference with election agenda to fulfill and to respect the deadline, action to gather community during campaign despite the public health risk, at local level or national election, lack of implementation of WHO and orientation, saying screening, tests, contact tracing, isolation. We didn't, in particular with COVID, did a lot of testing. Operational also, to decentralize the response while the pandemic is already community. Organizational structure was not also responding because there was centralized this response in the national level. And the socio-political environment also, there was underestimation of the magnitude of the outbreak at the beginning without a prompt decision to riposte. That was a very important thing, and we need to react, but on time. The difficulty also to apply the public health national emergency, that was with Ebola, but now politicians as well and local authority are more familiar to that health national emergency situation. And there was a lot of conflict among politicians and party, and that was a very impact negatively to the decision and the response also. And the issue related to the organization of the reports, there was high traffic and movement of positive patient, high risk contact and other body, lack of treatment center at the beginning. And we saw an impact of communication, social media, in real time on the communication risk mitigation. You know, when BBC, France 24, CNN saying, you know, these species have no vaccine, no drug, that means people say, why I'm going to die this, the treatment, Ebola treatment center? I rather say at my village, not going there. The uncertainty of scientific orientation, in particular with COVID, and that was a very critical situation because people saying mask is not useful, and then they are saying also there is no test, there is no enough vaccine. You know, such kind of things make a negative impact on the response also. The improvement of fundamental knowledge of the virus was very challenging also. Facility care and ambulatory care population acceptance to go to the dedicated health facility, and also the respect of community engagement and in particular ethical consideration during the clinical trial on public health emergency, rapid data sharing and the respect of global health security agenda as well as international health regulation. Now, in the Guinean perspective, we had an innovative approach with a tool funded by IDRC Canada. Why this toolbox? And for sure, Ebola outbreak research with human participants was very challenging in the most affected country. Ethical and robust research during and the aftermath of Ebola outbreak depend on community consultation, participation, and trust. Individuals and community on the participant side of the research have identified the need of support. And the title of this research was Strengthening the Ethical of Clinical Research with and for limited literacy participants in Ebola-affected country, a toolbox. As you can see, we developed with some three sub-Saharan countries this tool with a steering committee, but that was a very interesting thing, and you can see on the right the 10 right of participants during the research. I mean, these are the basic things that will allow community to know exactly the right. If they don't know the right, it's difficult to them to claim anything and to participate during their with a free consent form. And we develop a tool and video, key actor and decision maker in clinical trial, difference between clinical research and care, consent form to join or not to join the clinical trial, why the biosample can be an issue, how do we how do new medication make it to market. I think all these together give a lot of information, and there is a facilitation guide and to let people go through these tools. These tools are going to be posted in the website in Canada and in Africa also. I think we need to balance between governance capacity and legitimacy to handle public health emergency. That is a very important to develop capacity of the government, to have treatment center, to fulfill all these strategic response. But I think governance also and legitimacy of the community is very important. And at the end of the day, we think we need to uphold and restore trust in government arrangement for dealing with crisis. This is my last slide, and thank you very much for your attention.
Thank you so much, Mandy, for so much rich detail on the context from Guinea. We do not have a lot of time, but I'd like to make sure that we do get to some of the questions. So I'm going to jump right in with a question, first of all, for Dr. Harris Ali. This is a question from Ernest from the Democratic Republic of Congo. Ernest notes that one of the issues that divided the Ministry of Health and supporting partners was the use of the police or army in particular situations, such as those in Eastern DRC where armed groups controlled epidemic areas, making it difficult for response teams to access them, but also communities that were very hostile to government action. Negotiations are ideal, as you noted, Ali, but how do you go about things in these kinds of extremely tense situations?
Yeah, can you hear me? Yeah. Okay. Yeah. I mean, for our own research team, this what you point out here was actually a very critical sort of conversation for us between me and Masoka. Masoka, Dr. Falah had implemented the community-based initiative in Liberia, and it was very successful. But I was always concerned that the situation in DRC is a bit different because of the local context. And I was saying to Dr. Falah, we don't know the local politics of this area yet, and it's very complicated. But Dr. Falah was very confident that it doesn't matter, that because his approach, from his perspective was, first of all, we meet with all the community leaders. We have a sort of town hall meetings and have an open discussion. You see, so and kind of convince the people, like all the different community leaders that are there, about the importance of what we're doing with the Ebola response, and to get everyone on the same page, to have their concerns expressed, right? And so by having everything in the open, Dr. Falah hoped we would address a lot of these problems about conflict and all this sort of thing. Right. This is a sort of idealist perspective in my sort of perspective. So there was a bit of tension on that. So the securitization of response that you're referring to in this question is an important question. And, I don't have any set answer for that because you're kind of dealing with a volatile situation. We were trying to learn from the situation of West Point, where there was a standoff between the government, police, and army, and the people in this informal settlement, and about what led to the violence there and this sort of thing. But the context again is different in the DRC. So the best answer I could say in terms of negotiation, and I guess this is true of all negotiation, is to have a setting where you can be as honest and open about the concern as possible. And I know that sounds a bit like Pollyanna, as they say, but I know no other way to proceed.
Thank you. Yeah, and the securitization of humanitarian healthcare responses in general is just such a loaded and challenging question. We're gonna get a question now for Dr. Shelly Lees, please. This one is from Bob Goff at Western University. So Bob notes, in London, Ontario, vaccinations to healthcare professionals at local hospitals was recently halted to prioritize vaccinations in long-term care facilities. Being at greater risk of COVID-19 infection, long-term care residents and care providers were already identified as the first priority from the outset. How does vaccine implementation veer from planned priorities? And this undermines public trust in stated plans in conjunction with uncertain vaccine supply and providing first injections without reserving the second injection in favor of more people getting at least the first shot. So how does it veer? And I guess what is the impact on trust is what Bob is asking. And can history with Ebola, do you think, Shelly, inform us about the impact of such changing strategies? Oh, you're muted, my dear.
Thank you. I'm sorry, I was just saying thank you. And I think that's a really important question, something which we are grappling with here as social scientists. I mean, I think there are 2 points. One, that we have learned that public trust in science and the procedures of science are really, really important. So, you know, the idea that the British government is talking about different spacing between vaccines is quite troubling. It may not be problematic scientifically or safety-wise, but it could undermine trust if people think that hasn't been clear science to back up the justification for changing the spacing between vaccines. And I think in terms of prioritization and whether healthcare workers or others prioritize, again, these debates are really, really important. And I mean, there's a debate in the Guardian newspaper today about whether people from minority ethnic groups, people of colour, should be prioritised for vaccinations because they're at greater risk. These are really, really, really important debates, and how we have those debates in sort of high-income countries or sort of highly populated countries is something how we have community engagement or public engagement around these debates, I think, is a really, really important question. And we are grappling and thinking of ways that we can use social science to inform the ways to do these debates. Do you create a sort of local town hall debates around this? Do you have debates in the media? But not debates by specialists, but debates by the public. And so the public can be engaged in these kind of dialogues around these priorities. And what we certainly know from our work in Africa and elsewhere is that once you involve people in public debates, then first of all, anxiety subside, and then people feel that they have a say in the outcomes and the choices. And we've done that on such a local level around the vaccine trials. But how we sort of extend that, and I think this is probably important for Canada as well, how we extend that kind of model for conversation and dialogue to our much more sort of populated cities. I don't have the answer, and I think it's something I'd really, really like to discuss with others. But I think essentially, though, that question is that we are undermining, well, the politicians, I think, are undermining public trust, and it's very, very worrying. Thank you.
Yeah, thank you so much, Shelly, and thank you for that question. I know we can have a whole other session for sure on this. We have one last question. We have time for one last question for Mandy. This is a question from Cyril. Comment les facteurs socioculturels et religieux ont-ils été intégrés dans les programmes de déploiement et d'administration des traitements? Ont-ils constitué des barrières ou des facteurs facilitants? Alors, Mandy, est-ce que vous pourriez répondre, même si vous voulez répondre en français, on peut traduire. But this is a question about sociocultural and religious factors and whether or not and how they were integrated into response and treatment strategies. À vous.
Let me try in French because it's going to be easier for me. Il faut dire que les facteurs socioculturels et religieux ont été vraiment importants, surtout au début, puisque la culture veut qu'un décès doit suivre les rites habituels dans les villages. Et surtout, même comme il y a eu beaucoup de trafic, quand tu décèdes dans un village, tu es obligé d'aller dans un autre village pour être enterré, pour faire toutes les cérémonies. Et ça a servi à beaucoup à aggraver la transmission, surtout des villages vers les villes et inversement. Donc ça, c'était vraiment au début. C'est là où les socio-anthropologues ont été très utiles pour venir, pour faire comprendre aux gens la gravité de transporter des personnes positives ou des décès ou des contacts à haut risque qui doivent se promener. Et ça, c'est un élément extrêmement important. Quand il s'agissait de désinfecter les maisons, et il y avait des suspicions aussi pour dire, écoutez, tout ceci-là, ils viennent, les pompes sont empoisonnées, l'eau pour pour faire la sanitation. Ils n'avaient pas confiance en tout ça. Et même pour amener les gens au traitement, au centre de traitement Ebola, ça aussi, ça a été vraiment très, très défiant parce qu'il fallait leur faire comprendre l'importance que d'abord, la maladie est foudroyante et a une grosse fatalité. Donc, que vous restez ou que vous partiez, les chances de mourir sont grandes. Mais mieux vaut quand même aller parce qu'on avait des tests, on avait des médicaments sous investigation et qui ont permis dans certains cas d'alléger vraiment la situation. Donc, au début, les facteurs socioculturels, les points de vue des religieux, des médecins, des tradis praticiens ont servi à aggraver la situation parce que même les personnes n'allaient plus dans les traitements de routine, dans les centres de traitement de routine. Peu de personnes, tout le monde avait peur et on préférait aller chez les tradis praticiens. Et eux, les tradis praticiens, ont servi à amplifier cette transmission. Et c'est à la fin, et grâce aux socio-anthropologues, qu'on a pu cerner et puis renforcer la riposte dans ce qui se faisait. Je vais m'arrêter là pour permettre la traduction à vous.
Merci beaucoup, Manji. Et je mets la traduction dans le chat. Okay. Alors, c'est déjà fait parce qu'on est à 11h29, mais je voudrais remercier infiniment tout le monde. I really want to thank everybody for attending today and for your participation and great questions. We'll be saving the chat and sending additional questions to the presenters because they're really great and I don't know if they've been able to see them all. I'd also like to just let you know that our next webinar will be on February 16th and it's again being hosted and live streamed through the V-TRaC lab. And it's going to be on in what ways did the Ebola response influence the current COVID response in Africa? So really a continuation of our discussion here. I hope that you'll be able to join us again. And thank you very much to Dr. Harris Ali, Dr. Shelly Lees, and Mandi Kader for these great and complimentary and detailed presentations. Thank you.
Thank you so much.
Thank you.
Thank you.